Hi, I'm Dr. Anilasre, consultant obstetrician and gynecologist from Apollo Spectra, Chennai. Today, our topic of discussion is first trimester bleeding. It is an alarming sign both for the patient and also for the doctor. There are numerous number of causes which causes this bleeding. It can be a vaginal bleed, it can be from the anal canal, it can be from the urethra. Even sometimes bleeding from the nose and also from the gut. Of all, we are more, as an obstetrician, we are more focused about the vaginal bleeding. So to find out the cause for this vaginal bleeding, it is important to consult the doctor. So what could be cause for this vaginal bleeding? It can range from a simple implantation bleeding to a more serious problem like ectopic pregnancy. So let us discuss first what causes this bleeding. It can be related to pregnancy or it may be associated with pregnancy. Related to the pregnancy, the most common cause will be the miscarriage. There are different types of miscarriage to differentiate. It can be a simple threatened miscarriage where the pregnancy can continue with mild bleeding, where the pregnancy continues and goes on to a healthy baby. Next is a missed miscarriage, where the pregnancy has occurred but before the baby could grow, the pregnancy stops. Here they will be only may not have any much complaint other than bleeding. Next one is a inevitable miscarriage. Here, as the term implies, inevitable means where we cannot stop. It is already in the process of expulsion. So it is called as an inevitable. If it is completely expelled, we call it as a complete miscarriage. If the products are not completely expelled and partially left inside, we call it as an incomplete miscarriage. The next common thing is a ectopic pregnancy. Ectopic pregnancy is nothing but normally the fertilization occurs in the tube and then the embryo rolls on and get implanted into the uterus. If it doesn't roll back into the uterus and get implanted inside the uterus, then the pregnancy starts growing outside the uterus, what we call it as an ectopic, and the commonest site is the tubes. It can grow sometimes expelled outside and grow on the ovary or in any abdominal organ. These pregnancies cannot grow beyond certain stage and therefore they can rupture and cause life-threatening bleeding to the person. So it is very important to rule out this ectopic pregnancy, which is most of the time missed. The less common causes we have are the vanishing twins. As the name implies, one of the twin stops growing and then the second one grows as a normal healthy baby. That is, the one baby vanishes. The next one is a gestational trophoblastic disease. Of these, the hydatidiform mole is the commonest. This problem starts right at the time of fertilization. As the egg and sperm meet and develop into the baby, the sharing of the genes is not proper, which can lead to this gestational trophoblastic disease. Instead of developing into a healthy baby, the pregnancy will end up producing a grape-like structures filling up the uterus. So this cannot lead to any healthy baby. This can also produce vaginal bleeding when these small grape-like structures sometimes get expelled out. The other thing we should be aware is the implantation bleeding, which is a normal physiological phenomenon. That is, once the fertilization occurs and it gets implanted into the uterus, there can be mild spotting occurring. This occurs generally within 1 to 2 weeks of fertilization. With the advance in the technology of in diagnosing the pregnancy, This is where once a pregnancy test has become positive, there can be mild spotting, which need not be worried. Sometimes when the pregnancy has started with an IVF, those people, if they are not taking proper supplementation in the second half of the cycle or after the pregnancy test is positive, the progesterone hormone, then there can be a breakthrough bleeding. These are the common things where an pregnancy related vaginal bleeding can occur. Now let us discuss what are those which are related, not related but associated with pregnancy. Those can be local causes. Like there can be an infection in the vagina or the cervix. Cervix is nothing but it is the opening of the womb, the neck of the womb, which opens into the vagina. A simple infection also can cause a vaginal bleeding. There can be a trauma, a small growth over the cervix. All these can cause vaginal bleeding. Even a simple intercourse, because of the increased blood supply and softening of the cervix in pregnancy, can cause bleeding. Very rarely we can find small growth which may be related to a cancer. So it is very important to attend and get the reason for your bleeding. Of all these, apart from these, you should be aware that sometimes if because of the medical condition they are on some anticoagulants, that is drugs which are being used to prevent the clotting of the blood, like heparin, aspirin. These, when they are given in a high doses, can cause bleeding. So this also has to be told to your doctor when you have this vaginal bleeding and you are on these drugs. Now that we know the causes of bleeding, how to find out what is the cause for the bleeding? A detailed history and a physical examination is needed before going for any further testing. It depends on the amount of bleed, the color of the bleed, whether pain is associated with it, how long it's have been, is there a repeated episodes, any medication you are on, all these has to be known. Any other burning sensation in the urine, constipation, all these has to be. And what was the act you were doing when the bleeding started? All plays a role. Where a detailed history will be taken, and then if nothing, when some clue has been come, depending on that, we go for the examination. Most of this pregnancy not related to pregnancy, associated with the pregnancy, can be ruled out by doing a simple vaginal examination, where the infection or growth, everything can be seen. Once those associated with the pregnancy has been ruled out, next is the thing, what could be the cause for the bleeding from the uterus. For that, we have two investigations that we can do at this stage. One is a beta HCG, the pregnancy hormone, which is a blood test. The other one is an ultrasound. Ultrasound can be done mostly at this stage as a transvaginal ultrasound. Coming to the beta HCG, a single value of beta HCG may not be much predictive. At least two values are needed, especially when you are doing it at a very early gestational age, especially below 6 weeks. A single value, unless it is very high or low, is not much predictive. Very high value can be present in a gestational trophoblastic disease or a multiple pregnancy. If it is very low, then we need to think of whether the pregnancy is a delayed pregnancy or a failing pregnancy. So beta HCG has its own role in the early pregnancy. Coming to the key investigation for us is a ultrasound. A transvaginal ultrasound is a better modality, especially when you are doing it before 7 to 8 weeks. Ultrasound has its own advantages compared to the beta HCG. Here we can find out where the pregnancy is growing, whether it is an intrauterine or extrauterine. or rule out sometimes both your intrauterine and extrauterine can be present, what we call it as a heterotrophic pregnancy. So first thing is we can rule out the ectopic pregnancy. And once it is found that the baby is going inside the uterus, we can look for the fetal pool, the baby's fetal heartbeat. When the fetal heartbeat is good, we can check for any clots that are present close to the developing baby, what we call it as a subchorionic hemorrhage. This is one of the commonest causes for the threatened miscarriage. Then we can rule out multiple pregnancies. We can also rule out the gestational trophoblastic disease. In a scan, generally gestational trophoblastic disease looks with filled up just like a small grapes filling up the uterus. If the beta HCG is raising and it is above 50% raise from the first value, it implies that the pregnancy is a normal ongoing pregnancy, and we can think of doing a scan after a week if it was not found out in the first scan. If the beta HCG is increasing but not more than 50%, then we have to think of ectopic. So we need to check for other places other than the uterus, like the tube, ovary, other abdominal organs also have to be checked. If we did not find out, we need to monitor these patients to look where the gestational sac is present. So a careful monitoring is needed for these people. So we need any pain or bleeding after this episode has to be immediately reported. If it is not found out even after a week and consistently the beta HCG is increasing and it has reached beyond 1500, definitely we think of what is called pregnancy of unknown location. If the beta HCG is falling and there is no sac seen, then we call it as a failing pregnancy, and or it can be called as a biochemical pregnancy. Once a diagnosis has been made, what is the cause for this? Then the treatment will be directed towards the cause. Coming to the treatment, the commonest thing we encounter is a miscarriage. In a miscarriage, if it is a threatened miscarriage, we generally ask the patient to have some rest and give support with the progesterone, what is called as a pregnancy hormone. Around 400 milligrams will be given vaginally, advised to take twice till we see the gestational sac. If the gestational sac is seen and the fetal pole is good, we can continue them up to 16 weeks. This is only supplementation from outside. Even a subchorionic hemorrhage, we can do the same thing by giving the progesterone supplement and ask them to avoid intercourse and take some rest. If the miscarriage has become a missed miscarriage, then there is no other way. It has to be terminated at this stage. Either we can wait for it to expel naturally, or we can go for a medical or surgical intervention. In a medical intervention, we generally give misoprostol tablet vaginally and wait for it to get expelled. There can be an excessive bleeding and pain when the products are getting expelled. In a surgical method, it is a simple one and a safe procedure which takes only 15 to 30 minutes. Under anesthesia, the cervix will be opened and a small suction apparatus will be kept and sucked out all the products. And generally, the bleeding post surgical evacuation may not be heavy. And it is a daycare procedure and the patient can go home once anesthesia effect is gone. Both medical and surgical are safe. Only thing, medical may take little longer time and there may be mild pain known to the patient. Surgical procedure, you have to admit and go through the anesthesia and the procedure. Both has a good success rate, but medical, if the expulsion is not complete, then we may go for a surgical evacuation. So we have to monitor the medical post miscarriage. We have to monitor these patients whether it is been complete or not. If the patient have any excessive bleeding or pain after the expulsion, then they have to report immediately. Otherwise, we do a scan or a urine pregnancy test after 2 to 3 weeks and a follow up to see that it is complete. Coming to the incomplete abortion also, we have to do a surgical procedure. Once it is complete, nothing else is needed. We need to say that if the patient have any pain, fever or abnormal discharge, to report immediately. The next one is a ectopic pregnancy. In ectopic pregnancy, the pregnancy cannot go beyond certain period. So we have to terminate. It can be done either medically or surgically. You cannot do medical management has its own criteria and we cannot apply it for everybody. But if it is, if you are eligible for a medical procedure, a single injection will be given of methotrexate in the buttocks, and the beta HCG, the pregnancy hormone, will be monitored after a week to see that it is coming down. If it hasn't come down, then a repeat dose has to be given, second dose after a week. This has its limitations that we cannot use if the sac diameter is greater than 3.5 and the fetal heart is present and the patient has already had ruptured or the patient have a liver disease. Coming to the surgical procedure, it can be done by open surgery, that is laparotomy, or they can go for a laparoscopic procedure. In this, we have two things mostly. As the tube is the commonest one, we try to remove the tube wherever the ectopic has developed. That is called as a salpingectomy. If the tube, we feel that the other tube is not good, or we can go just for the removal of if the patient doesn't want removal of the tube, then we go for what is called as salpingostomy. That is, a small nick will be given over the growing pregnancy and the products will be removed through that cut, and the patient will be followed up by beta HCG to see that totally all the products have gone. Those who have got an ectopic pregnancy must be very careful in the next pregnancy, because there is a small increased chance of getting an ectopic pregnancy even next time. So you have to report immediately once a pregnancy test is found to be positive. Same way, if you have taken methotrexate injection, a reliable contraceptive has to be used for 3 months so that the conception doesn't occur, because methotrexate found to be affecting the fetus. The next one is a gestational trophoblastic disease. For a gestational trophoblastic disease, we would advise to go for a suction evacuation, send this whatever products have come for histopathology to see what type of gestational trophoblastic disease it is. It will be a hydatidiform mole or a choriocarcinoma. If it's a hydatidiform mole, it can be partial or complete. Both of them, generally we follow up with a beta HCG for a couple of months, from 6 to 12 months, depending on the drop in the level of the beta HCG, and advise not to conceive during this time. A proper reliable contraceptive has to be used during this period. Coming to the these, most of them don't, they are all benign tumors only, but there is a small chance of converting into an invasive or a choriocarcinoma. That is why a follow-up is very important. If it is a choriocarcinoma, they have to go through a chemotherapy. They will be referred for the further follow-up. The vanishing twin generally does not cause much problem for the developing baby, but the pregnancy may behave like a multiple pregnancy. That is, the baby growth may be slightly affected and the growth will be as a twin baby. Most of these people who have had excessive bleeding and they have a negative blood group with the husband having a positive blood group, it is better to take an anti-D, especially when the bleeding is heavy or you have undergone through some operative procedure. In conclusion, to say, all vaginal bleeding need not be a panicking state. It is very important to consult a doctor and find out what is the cause of the vaginal bleeding. Accordingly, the treatment will be related.
Hello doctor, does bleeding have an effect on this pregnancy?
A mild bleeding in the first trimester may not affect the pregnancy, but there may be a small chance of having a PROM, what we call is as early rupture of membranes, before the baby has reached to term, that is near 40. Other thing is the growth may be slightly affected, which will need to be monitored throughout the pregnancy. Otherwise, most of the babies who had even a first trimester bleeding come out as a healthy babies.
Doctor, does travel cause any risk for bleeding or miscarriage?
If the pregnancy has been a normal pregnancy with a good implantation, travel should not cause any disturbance with the pregnancy. They say that a normally implanted pregnancy, even if you ride a horse, should not be disturbed. If the patient have a past history of miscarriages, then she needs to be careful, especially when traveling on a roads. Rail travel and the air travel should not cause problem in the first trimester.
Doctor, does vaginal examination safe to do while bleeding?
Yes, vaginal examination and even a transvaginal scan does not increase the risk of miscarriage. Maybe if you have an erosion or some lesion on the cervix, the bleeding may be repeated or triggered after vaginal examination, mild. Otherwise, if it is from the uterine bleeding, generally it should not cause any problem.
Doctor, which is better, surgical or medical management for abortions?
Both has its own pros and cons, and both are safe. Coming to medical management, if you take a proper follow-up is very important. So it is very important that you take the medication that is being prescribed, and also the bleeding can be slightly high and the pain will be there when the fetus is getting expelled. Coming to the surgical, you have to get admitted in the hospital, but it's a single time procedure and no pain or anything. Coming to the infection, there is both of them have its equal chance of getting infected if proper precautions are not followed and antibiotics are not taken after a surgical procedure. During surgical procedure, there is a very small risk of getting a uterine perforation or trauma to the structures. Otherwise, both are safe.
Doctor, what are the precautions that need to be taken after miscarriage?
Generally, immediately post miscarriage, we advise to come back after 3 weeks. First 2 weeks regarding contraception, you need not worry because the ovulation starts only after that. So it is very important that till the bleeding stops, or at least for 2 weeks, not to have intercourse, not to use tampons or the menstrual cups because it found to increase the risk of infection. And any excessive bleeding or pain or fever, abnormal discharge has to be immediately reported to your doctor. And also coming to the work or travel, you can go back as long as you feel comfortable.